Hello, I'm Dr. Alan Meltzer, and it's a pleasure to be here with the people from Dental XP. And this morning I want to share some thoughts with you on the direction in which I think implant dentistry is going. There's no question that there are two areas that are primarily being looked at today. The first is improving aesthetics, and the second is providing patients with teeth sooner, or immediate and early loading. I want to review with you some of the concepts of the biomechanics of early and immediate loading and how new advances in implant macro, micro, and nano design are helping us achieve that outcome. I want to today share with you my thoughts on the subject on the biomechanical management of complex patient subsets. The word that always comes to mind when dealing with this topic is biomechanics. And if we break down the word biomechanics, we break it down into two subheadings, biology and mechanics. If we really want to understand what is happening in the world of implant dentistry, the word is really backwards. The word should be mechanics biology. Because when we first insert an implant, it is mechanically stable. And if we do that properly, over a period of time, weeks for example, the conversion occurs from mechanical stability to biologic stability. So I'd like to begin by talking about how we can establish high primary or mechanical stability. There are several things that control this mechanical stability. They include the bone quality. In other words, we placing this screw into a material that is extremely dense, like oak, or are we placing this screw into a material that's extremely soft, like styrofoam? The implant macro geometric shape controls the primary stability. The taper of the implant, the thread pitch of the implant, the platform design of the implant, the insertion torque of the implant, the precision of the osteotomy site, the strength and direction of the occlusal load. Are we loading this implant axially or are we loading it off axis? We then have to consider, are we splinting these implants together or viewing them as individuals? And finally, if we are splinting them together, are we splinting them in a straight line or around a curve? All these factors influence the primary stability or mechanical stability of the implant. One way, looking at a traditional parallel-walled or straight-wall implant, that I believe we can increase primary stability is by undersizing the osteotomy site. I use undersized drills to place my implants in virtually all qualities of bone. In type 4 bone, I will use a 2.75 millimeter twist drill or at most a 3 millimeter twist drill to seat a 4 millimeter implant. Even in the densest of bone, type 1, I would never go larger than a 3.15 millimeter drill to insert the 4 millimeter implant. There always arises the question of pressure necrosis. Well, I view pressure necrosis as a unicorn. Why do I call it a unicorn? Because everybody knows what a unicorn is, but nobody's ever seen one. And if you review the literature, there is really no controlled study demonstrating pressure necrosis. Bone is a viscoelastic material and will respond very well to compressive loads. If we change the subject slightly and change the shape of our implant slightly and include an expanded platform in the implant, we can definitely see advantages to this. The expanded platform is designed from a mechanical standpoint to engage the best quality of bone. If we have decent bone anywhere, the decent bone is going to be on the cortex, the outer surface of the available bone. Why not use a macro design that is designed to engage that cortical bone and provide greater primary stability. Another newer alternative is a tapered implant. Tapered implants are very critical when it comes to macro design. When we look at a tapered implant, the only time a tapered implant achieves maximum primary stability is when it is completely and thoroughly seated in the osteotomy site. When we have a straight wall implant, we can have high primary stability wherever we put the implant in a vertical direction. Think about sliding one piece of PVC pipe inside another. You don't have to completely seat one inside the other to have good lateral stability. However, if you're going to seat a wedge inside of a wedge, the only time you can maximize primary stability is if that implant is completely and utterly seated in the osteotomy site. So if we are going to elect to use a tapered implant, we must be willing to use the hand ratchet. We must be willing to realize that these are high insertion torque implants, and we must be willing in our philosophical approach to thoroughly and completely seat this implant in the osteotomy site utilizing a hand ratchet. Let's go back for a minute and talk a little bit more about the mechanical advantages of an expanded platform. If you properly seat the expanded platform in the osteotomy site, and then we elect to place an undersized abutment on this expanded platform, we achieve what I call an outrigger type effect. We achieve an ability to centralize occlusal forces. Platform switching has been talked a lot about from the standpoint of improving crestal bone preservation biologically. But I want you to think of it a little bit differently in improving initial primary stability mechanically. If we keep the occlusal forces inside an expanded platform, we decrease the risk of establishing micromovement in the body of the implant. Once we understand how we can improve primary stability or mechanical stability through macro implant design, we now have to talk a little bit about what happens biologically in the transition from mechanical stability to biologic stability. And what really happens, as was explained in the literature, is over a period of weeks, the mechanical stability begins to decrease. At the same time, the biologic stability begins to increase. Where those two lines cross, we end up with a dip between the primary and secondary stability. It is that dipped area during the transition that the implant becomes most susceptible to failure. So there are two ways of solving this problem. The first way is to push the primary stability curve further to your right. The second way of solving the problem is to push the biologic stability curve further to the left. If we can compress these two curves together, we can eliminate the dip, and by eliminating the dip, we can achieve what we call steady state stability. And if hypothetically we could do that, we could then make more cases available for immediate and early loading. Let's take a look at a little piece of history for a minute. And the question I'd like to ask you is, why was it that when we first started immediate loading 15 years ago or so, we began by loading an edentulous mandible? Was this just a happenstance, or was there really a reason why this began to be done in the edentulous mandible? And if you think about this mechanically, the edentulous mandible provides the best bone. It's the oak of the oral cavity. We are using multiple implants. We are splinting the implants together, and we are splinting them around a curve. Now, when this was done originally, the implant that was available was a machine surface implant. So the dip here was eliminated by increasing primary or mechanical stability so much that the implants could withstand the dip and move into biologic stability. So if we begin to understand here that the solution was purely a mechanical one, we can now move further into the newer field of implant dentistry and look at how we can improve the situation from the standpoint of more rapidly gaining secondary or biologic stability. How can we alter this dip that occurs biologically? And to do that, I want to introduce you to a little experiment that we performed. And the experiment basically looked at how surfaces impact this dip between primary and secondary stability. If we begin by looking at Glauser's research on machined implants, and we measure the alteration in primary stability over time, we see that during the first several weeks, there is a precipitous drop in primary stability. And it's interesting to note that this drop continues until we get out around 3 to 6 months. It's interesting when we begin to think about the 3 to 6 month time period, because when were we told we could load machined implants? 3 to 6 months. Just about the same amount of time as it took to overcome the dip. If we look at a dual acid-etched implant surface, in this case the osseotite surface, we see that again there is a dip. It's not quite as deep, but it is significant. And the dip begins to recover at around week 6 and is fairly well recovered by around week 8. When were we told we could load dual acid-etched implants? With early loading, we were told that we could load these implants around week 8. I think it's interesting to see that the dip begins to recover at around the 8th week. If we now look at a new nanobiologic implant surface with both micro and nano complexity, we see a very interesting finding. There is a dip, it's not very deep, and it recovers virtually immediately. If that is the case, then this may be part of the solution towards combining macro shape and design to improve primary stability and micro and nano surface technology to push the biologic curve together and therefore eliminate the dip. And this phenomenon we call steady state stability. And the hypothesis becomes, if we can minimize the dip by improving primary stability and optimize surface technology, and through that improve the speed at which biologic stability is established, more cases, more partially edentulous cases, become candidates for immediate loading. I'd like to conclude by just showing you a brief video of how we combine these concepts together. There certainly is literature that is currently out there that the length of this presentation does not give us the possibility to include, but there is sound literature on the use of this new technology in short span bridges with high degrees of success. Here we're removing a crown from a single tooth, and as you will note, once the crown is removed, a vertical fracture becomes apparent. The tooth is extracted, and now the intactness of the facial plate is being evaluated. Once we find that the facial plate is intact, the next thing we do is look at the relationship between the free soft tissue margin and the crest of the intact facial plate. That is going to serve as our guide for implant placement. Here we are beginning our implant placement utilizing a spear point burr. We now, utilizing our philosophy of undersizing, are beginning to slightly expand the osteotomy site with a 2mm twist drill. We are taking it to depth, always keeping in mind that the implant needs to be tucked behind the facial plate of bone. Verifying the position of our implant utilizing a guide pin. Since we are going to be using a tapered implant to maximize primary stability, we begin preparing the site with a 3.25mm shaping drill. And again, always preparing the site so that the implant will be tucked behind the intact facial plate of bone. Verifying the site with a 3.25mm direction indicating pin. We are now going to expand the site using a 4mm shaping drill and taking it to depth, verifying the site once again, and now finally expanding the site using a 5mm shaping drill, always being careful to prepare the site so that the coronal portion of the implant is always tucked behind the midfacial plate of bone. If the midfacial plate is compromised, and by it being compromised we would have to place the implant too deep, in my opinion that then becomes a poor candidate for immediate placement and becomes a candidate for site preparation prior to implant placement. Here you can see our tapered implant, and it is being inserted at 40 RPMs with an insertion torque of 50 newtons. You will notice that the implant stalls out long before it is finally seated. What we are going for here is maximizing primary stability. We will then finish seating the implant utilizing a hand ratchet. And I want you to notice how aggressively we are utilizing the hand ratchet to make sure that this wedge-shaped implant is completely seated in the wedge-shaped osteotomy site. This implant has also been treated with a nanotight nanobiologic surface. So here we are establishing high primary stability. You'll note that with the Ostel device, our initial primary stability is 82, which is extremely high. Notice that the abutment that we're selecting for this immediate load project has a 4.1mm platform, even though our implant has a 5mm platform. Platform switching for two reasons. Mechanically, centralizing occlusal forces. Later, biologically, preserving crestal bone. The tooth is then restored on this provisional post. We then wait 8 to 12 weeks and move forward with our restoration. Here we are trying in our crown. Notice that we put two little wings on the crown so we make sure that it's being seated properly apico-occlusally, and then the wings will be removed. Our abutment is adjusted extraorally. It is seated. Our crown will be tried in and cemented in place. Here is our temporary abutment seated. The crown is tried in. So here we're just going to seal the access cavity in this temporary abutment. The temporary abutment that we use is made of polyether ether ketone. It's inexpensive, it's stable, and it's utilized during the initial healing phase and to get us through the transition from mechanical to biologic stability. Final try-in of the crown. We very much like to make our provisional crowns with these two little wings on them to initially position the crown properly and make sure that everything fits passively. And then, as previously stated, we will cut off the wings before we deliver the final restoration. The abutment is lubricated. The shell is filled with acrylic, seated in place. The wings are now cut off the crown, and it is seated in position. The last step involves the placement of a non-absorbable bone graft between the buccal surface of the implant and the palatal surface of the buccal plate. We believe here in using a non-resorbable material because if this micro gap is not packed, it is not an issue of the gap not filling with bone, it's an issue of the way that micro gap fills with bone. That micro gap will fill with bone by the buccal plate moving back toward the implant. If we do not fill that micro gap with a non-resorbable material, then over time, the facial soft tissue covering the implant will collapse toward the palate. So I like to call this non-resorbable bone graft the breast implant of implant dentistry. By that I mean that this material is put in there to maintain the illusion of the buccal plate being far to the buccal and therefore improving the aesthetics of the situation. A small piece of collagen sponge is inserted on top of the graft. It is simply tucked under the flap. This is not a regenerative membrane. This little piece of collagen becomes a graft containment device. The crown is then seated and the case completed. I want to thank you for giving me the opportunity via Dental XP for sharing some of my thoughts with you about the biomechanical management of implant dentistry and how the alteration of macro shapes and micro and nanotechnology will enable us to move forward and treat more complex patient subsets, achieving the objective of providing our patients with fixed restorations in a less invasive manner sooner. Thank you.